way round. Good morning, everyone. We are going to get started shortly in about 2 minutes. Just letting everyone come in. Okay, I'm going to get started because we've got a lot to get through in the next hour. Just want to say a massive welcome and thank you for coming today to this webinar on ectopic pregnancy. And this webinar is going to cover everything to do with remote and pre-hospital care. You'll see the National Pre-Hospital Maternity and Newborn Care email group at the slide at the moment, and you're welcome to contact us after the webinar with any questions. So I'm just going to run through a couple of bits of housekeeping. My name's Camilla. I'm a consultant midwife for East Midlands Ambulance Service and one of the lead midwives at the London Ambulance Service. You're going to meet the other one shortly. And I'm going to just take you through the housekeeping before we kickstart. So just everyone who's on this webinar is welcome, but just so you're aware, this webinar is intended for people that work in the pre-hospital setting, so ambulance clinicians and people that work in ambulance control rooms. If you don't work in either of those settings, you're still welcome to be on this webinar. It's just that your guidelines and what we would expect you to do may be slightly different to what is going to be presented in this webinar. This webinar will be recorded. This is so that it's available for people that weren't able to make it today. It will be available on our national YouTube channel, which you can see on the screen right now. You can find using the handle at PreHospMatNeo UK. If I can just ask everyone who's not talking, which should just be me, to go onto mute, please. That would be really helpful. Thank you so much. And if we can just continue that throughout the webinar, if you can just stay on mute for us. Thank you so much. We'd love you to use the Q&A function through the webinar. Please don't use the chat function. We've just had feedback previously that it can cause distraction and to the speakers, but also to the people that are listening. And we'd rather that you use the chat, the question Q&A function for questions. What I would say is once we get to the Q&A part of the webinar, then you're welcome to put comments, feelings, things that you want to say to the presenters into the chat as well. But questions, please put them into the Q&A function, which should be at the top of your screen. Just be mindful of your own trust values when you're raising any points or asking any questions, please. We will be presenting a case today. What we would say is that we have anonymized the case, but what we would really appreciate you doing is spreading any learning that you have received today at this webinar to other colleagues. If you learn anything today, please make sure you tell at least 10 of your colleagues so that we can disseminate the learning wider than just the people that are able to be here today. And there will be an opportunity to evaluate this webinar because we are hoping to put on more national webinars on topics like this, where we can get an external expert or a particular topic that doesn't necessarily need the practical element going through. So please let us know if there are topics that you'd like us to cover in future. And finally, just to say that we're obviously covering this topic in the next hour. We are holding a national pre-hospital maternity newborn care conference in October in Newport, Wales, and you'd be really welcome to join us. We'll be going through many other pre-hospital specific topics at that conference. So thank you so much, and I'm going to hand over to Rachel. Um, Rachel's kindly joined us externally. She's clinical matron for gynecology and early pregnancy unit at the University of Birmingham Hospitals. She's also chair of the Ectopic Trust and previously was chair of the Association of Early Pregnancy Units. So thank you so much for joining us, Rachel.
My pleasure, thank you. I hope you can all see the screen. Thank you for inviting me today to come and talk to you all. It's a real pleasure. In the day job, the unit I work at has a lot of interaction with our local ambulance service, and it's a service that works really well with direct access. And I know I'm going to be talking about that in a few months' time at a conference that hopefully some of you will be coming to. So today I've been asked to talk about raising awareness of ectopic pregnancy. And this is a real passion of mine. Obviously, I run an early pregnancy unit, so it's our bread and butter. It's what we say day in, day out. But I'm also very aware to you guys, it's probably more of a rare thing that you see. You're not going to see it every week. So this is just going to be a whistle-stop tour, really, of what ectopic pregnancy is, and then what tools the Ectopic Trust have brought in to really try and support you and guide you with dealing with ladies in the community. So I was going to start with, sorry, let me just, okay, can you see the next slide? Yeah, okay. So what is an ectopic pregnancy? So we know it's a pregnancy that's not in the uterus. So straight away, it's not in the correct place. It should be in the fundus of the endometrium in the uterus, and it's where that pregnancy is not where it should be. And the incident is 1 in 80. So every 80 pregnancies, one would be an ectopic. We have 12,000 cases in the UK every year. And we also know that it causes 10% of maternal deaths throughout the whole of the UK, and that is due to the torrential bleeding it causes. This is just a nice reminder from the Embrace report that it is still there. Early pregnancy is still a cause of maternal death. And these are just some examples of what's hit headlines over the past few years of patients that have unfortunately passed away with an ectopic. So as I mentioned, Embrace obviously looks into all causes of maternal death, including early pregnancy. And it's reminding us really that women are still dying from ectopic pregnancy, where we're living in a country where, getting access to healthcare timely means these ladies don't need to lose their lives. So the fact that they are is heartbreaking. What was found in the recent Embrace report was vulnerable and young women are mainly disproportionately represented. And all women that did die of the ectopic pregnancy could have had better care. One of the main things Embrace found was its recognition of the ectopic and then timely access into the gynae early pregnancy units. So looking at types of ectopic, so we know that the majority of them will be in the fallopian tube. That's where the majority of them will implant after conception. But we do get them in really also unusual places. And the reason I mention this to you is some of these unusual places, these ladies may end up getting conservative or medical treatment, which means they go back into the community while they're undergoing this treatment. So it's just being aware that they're not always in the fallopian tube, they can be elsewhere, and also they're not always treated with surgical management. And that's just a nice diagram of where they can be. And this is particularly exciting for people like myself that scan in early pregnancy where we have to go hunting for where the pregnancy is. So important for you guys is signs of an ectopic pregnancy. So being in the community, I can imagine it's really difficult that you've got a lady in front of you, you may not even know she's pregnant, and then we're asking you to think ectopic. So what signs do women report? What are the main signs? So positive pregnancy test. I know that might seem ridiculous that we've put that there, but believe me, when the amount of ladies we get that aren't referred into us or that are referred into us that don't even have a pregnancy test done. So it's checking with the woman to see has she had a pregnancy test done. If the woman says, no, I'm absolutely not pregnant, there's no way I can be, as much as I believe that women need to be believed, I also, in my experience, have known many women that honestly didn't know they were pregnant, didn't think they could be pregnant, and actually were. So we're talking about a life-saving treatment here. So sometimes it's about supporting the woman and understanding that she's adamant, but also asking her, would she just entertain you and do the test just to be absolutely certain? So the main sign of an ectopic pregnancy is she will complain of abdominal pain or some kind of pelvic pain. They can have PV bleeding. This is more associated with light PV bleeding, maybe brown in colour, but not your typical miscarriage history where they're having a really heavy bleed, passing clots. This is more sort of, it can be intermittent. They can bleed for a day and then nothing happens for a couple of days and they bleed again. That's very common with an ectopic. Bladder and bowel problems. So really important that it can mimic a UTI. A lot of reviews that I do, it is quite astonishing how many women have been treated for a UTI before the ectopic's been diagnosed. And also bowel problems. So we know that a woman, especially with an ectopic pregnancy that's maybe ruptured, so she's got some free fluid in her pelvis, she will get signs of diarrhea and that urgency. And that is a quite common symptom that we see, that ladies will come in saying, oh, I constantly feel I need to go to the bathroom. And that they feel they've got a bit of a what they would call dicky tummy. And that is also a red flag for us. Rectal pressure, and again, this can be because of the bleeding in the pelvis, but again, if they're telling you that they're just constantly getting this pressure to go to the toilet but nothing's happening, again, this is a red flag. Shoulder tip pain, that's a very common sign. Tachycardia, hypotension, and then unfortunately we do get to shock and collapse and potentially death. It's remembering that most women that have an ectopic pregnancy are young and healthy, so they will compensate for a long time. So once they get in the tachycardia and the hypotension, we're actually looking at it being a bit late, and they're heading towards that shock and collapse. So we don't really want them to get to that stage. So if you are in a home with a woman who's having this pain and she's got a positive test, but actually her signs are completely normal, don't be reassured. Please don't be reassured, because she will compensate for an awful long time. And when she does start showing signs, it can then be very fast when she actually goes into cardiac arrest. So please don't rely on her vital signs to give you any kind of reassurance. A third of patients will show no signs. These are the ladies that will come into the early pregnancy unit or they've gone to their GP with some complaints about something else, and they've come for a reassurance scan, and we've actually found it on scan. So I know that's quite surprising, but yeah, we do see a third of women with no signs. So what are the risk factors for an ectopic pregnancy? Pelvic inflammatory disease, having a previous ectopic. So even having a previous ectopic doesn't mean that you've got a really high chance of having another ectopic pregnancy, but your risk is slightly increased. Previous surgery, for example, if a woman's had tubal sterilisation. Fertility treatment, having emergency contraception, having known damaged fallopian tubes, smoking, being over 35, but a third of women will have no risk factors. So that's why we have a standard in EPU where we say positive pregnancy test with no scan, treat as ectopic until known otherwise. So management of an ectopic pregnancy. So we can treat it expectantly. So this is a watch and wait approach. This is offered to stable women that are pain-free, that the mass that we can see on scan is less than 35 millimeters, the beta HCG is less than 1,000, and she's got no free fluid. And the most important criteria is that she'll attend follow-up. We won't give this to a lady that we know won't engage with us, because it's not right we send an ectopic back out into the community of a woman that's not going to conform to treatment. So we always make sure we've checked safeguarding and we've checked her ability to conform. But it's important you know about these ladies being in the community, because they will be told that if they do suddenly feel unwell, they get severe pain, and they get any, because we safety net them, they will be told to call an ambulance if they suddenly feel very unwell. And they will be telling you about the treatment that they've had. So it's important that you know that these women will come out into the community. Then we give medical management. So this is methotrexate. We give this to stable women with no significant pain. So as you can see, it's similar to expectant. The mass is 35 millimeters or less, but her beta HCG here is a little bit higher. In most units, it's 3,500. The NICE guidelines do allow us to go up to 5,000, but that's consultant decision. But otherwise, most units, it's 3,500. No free fluid, no contraindicators to methotrexate, and again, important, can attend follow-up. With these ladies, they're coming to the unit twice a week to have their bloods monitored, and they're discharged once their beta HCG goes to 0. Again, they will be coming in and out, so they'll be in the community, and again, they'll be told if at any point they start having any severe pain, they must call an ambulance. So again, it's you being aware that these ladies are in the community. And then our third option is surgical management, and these are for our unstable patients who are in pain. The mass is significantly bigger. Her beta HCG is over the 3,500. And also, if it's a live ectopic, we wouldn't consider a live ectopic having the other treatments because of the rate it grows at and the risk of rupture. Just wanted to briefly touch with you on pregnancy of unknown location. So an ectopic pregnancy is diagnosed when we can see the ectopic on scan. But we do get a group of ladies who will come in and they're scanned and we can't find where the pregnancy is. So obviously we're going to be at that point assuming they're ectopic until known otherwise, but it could be other causes. If this woman is stable, we're not going to keep her in hospital until we know where the pregnancy is. We're going to follow her up throughout the weeks and treat accordingly. So again, these ladies will be back in the community with you. So it's you being aware that she'll have a scan report in her hand that she'll be told to show any clinician that is dealing with her, and it will have pregnancy of unknown location written on it. So just to go through what that means. It's a classification, not a diagnosis. So it's a working classification. We're trying to find out where this pregnancy is. So just because she's got PUL written on her chart doesn't mean that's a diagnosis. It just means we don't yet know what classification she sits in. So just to make you aware, 40% of all PULs will be an ongoing early pregnancy. And the reason why we're not finding them is women are presenting earlier and earlier. I'm sure we have thanks to our pregnancy test companies to thank us for this. Women used to present 2 weeks after their period. Now they're encouraged to do a test even before they've missed their period. And then they'll get bleeding, they'll get pain, and they'll access the unit. And as you can imagine, these pregnancies are so small, we can't see them. So 40% of these women will be an early intrauterine pregnancy. Then around 50% of them will be a failed pregnancy. So this will be a miscarriage. So this is that they've had some kind of bleed, or they've had some kind of incident happen where they've come in after the event. So when they've been scanned, we can't see anything on scan, but their pregnancy test is still positive. And 50% of them will go on to be told that they are a miscarriage. Ectopic is around 5 to 20%. Now, the reason it's 5 to 20% is based on how good the unit is. So what I mean by that is, how good are your scanners? So if you've got a unit that is very remote and you've got one sonographer who goes between all the departments in radiology and they do one session in early pregnancy, their PUL rate might be around 20%, because actually they don't see it all the time. But then you might have a big teaching hospital that's also a tertiary centre that has patients sent in from all different areas, and their rate's going to be 5%, because their scanners just scan early pregnancy every day of the week. So they are more au fait with diagnosing an ectopic or seeing an ectopic. So that's why that percentage is different. And of course, depending on where you are in the country, depends on what that rate will be. And then we have a persistent PUL, which is more rare. And this is when we never find where the pregnancy ever was. The beta HCG goes to 0, but we never actually found where it was. That, as I said, that is more unusual. We don't see that very often. It's normally between the 3, an ongoing, a miscarriage, and an ectopic. But this is just so you're aware that if someone's in the community and they're saying they're a PUL, this is what we're looking at. This is what we're working to. So what can you do out in the community, seeing these patients in their homes? So what we want you to do is think ectopic. Think a little bit like the sepsis pathway, where we're asking you to think sepsis, where you're doing your observations and you're thinking, your first thought is going to, do I need to start the sepsis pathway? We want it to be similar with think ectopic. So basically, the Ectopic Trust have bought in this campaign, and we've got these small bio cards which you can get online. You just scan the QR code and it will be sent to you. So this is just a very small bio card with all the symptoms on it. That's just a bit of a tool to remind you. So when you're in a woman's home, is she between the age of 12 and 55? Is she sexually active? Therefore, think ectopic. And it may not be ectopic, it may be a UTI, but it's just straight away removing from your possible diagnosis what it could be. And even if it means straight away you exclude it, then that's a great thing. So you can request them online. So what we want you to do is, any woman that's missed her period, has got UTI symptoms, she's got pain, vaginal bleeding, rectal pressure, she's had fainting episodes, and she's between 12 and 55, we want you to think ectopic and perform a pregnancy test. If she has got a positive pregnancy test, we want you to bring her to gynae. That's where she belongs. That's where she needs to be seen. There have been a few HCID cases that have gone through, and they brought up they endorsed the Think Ectopic campaign as well, and they have put safety alerts in all A&Es that support the campaign. And I'm happy to take any questions that you've got.
Thanks so much, Rachel, for that really helpful presentation. We're actually going to move on and then do questions at the end, if that's all right. So the next presentation is going to be from Bethan Jones. And Bethan works for the Welsh Ambulance Service as specialist clinician in remote care for maternity. So over to you, Bethan. Shall I share your slides for you?
Yeah, that'd be great, Cam. Thank you. Good morning, everyone. So as Cam said, I work in the Welsh Ambulance Service, so I'm just going to look at our JR Calc guidelines when we're thinking about ectopic pregnancy. So at the beginning of this year, we separated out bleeding in pregnancy to under 20 weeks and over 20 weeks. So under 20 weeks is where we are going to be looking for this guideline, and within that guideline you can then see the ectopic drop down. So Rachel's kindly covered most of this, but just refreshing that in the prehospital context, the most likely cause of bleeding is going to be miscarriage or ectopic pregnancy. The thing we need to be aware of here is bleeding may be largely concealed internal with an ectopic pregnancy, so we're not always going to see the blood loss. A pregnancy that's implanted outside of the uterus, which Rachel's already mentioned. So ectopic pregnancy, the history that we should be raising suspicion is a previous ectopic pregnancy, an intrauterine conceptive device, and history of pelvic inflammatory disease, sterilisation, reverse of sterilisation, or any other tubal surgery, and superfertility, which is a delay in conceiving. Go on, Cam. So the common symptoms suggested of ectopic pregnancy. So for the majority of people working in an ambulance service, we are going to be unable to do a pregnancy test, and even more so in the remote setting. So we may not have that confirmed. So we need to be really suspicious when thinking ectopic for these patients remotely and face to face. So it typically presents between 6 to 8 weeks gestation. So there's only usually one missed period, which women may forget about. Cramping or lower abdomen or pelvic pain, vaginal bleeding. And if we just have a little look of those sanitary pads there, so all of those sanitary pads show 50 ml blood loss. So as you can see, just asking that one question of, is your sanitary pad saturated? It's not going to give us a good indicator of the blood loss, and that's just something we need to be aware of. Sanitary pads are becoming better and better in 2025 and can absorb more fluid, so that's just something we need to be aware of when we're trying to understand the amount of blood loss. Other symptoms suggested of ectopic: unexplained dizziness, fainting, shoulder tip pain, and bowel symptoms, as Rachel's already covered, and urinary symptoms. So signs of possible ectopic pregnancy. So all of this is within the JR Calc guidance, may be minimal or absent, tachycardia, pallor, posture, hypertension, abdominal distension. Signs of developing peritonealism is abdominal tenderness or guarding and rebound tenderness. And I think for our colleagues working in the remote settings, in the remote clinical settings, we just need to have that extra suspicion with any women ringing in to 999, because these calls may come out as a low priority if women are ringing with these symptoms. So symptoms of sign of a ruptured ectopic pregnancy. So when we're thinking about Rachel's presentation earlier, as she said, by the time women are starting to show these signs, then it's already too late. This is signs of rupture. So acute severe lower abdominal or pelvic pain, shoulder tip pain, and this is due to the diaphragmatic irritation from the blood within the abdomen. Pallor, clamliness, plus or minus cool skin. Tachycardia, plus or minus hypovolemic shock. Rigid tender abdomen, plus or minus guarding, and rebound tenderness. So this is your maternity decision tool, which is also within JR Calc. So the QR code is there for anyone that wants to refresh yourself with the maternity decision tool. And what we are just showing you is that your maternity decision tool will support your decision making if you are thinking that this is a suspected or confirmed ectopic pregnancy. So what we try to reinforce through this tool is something that we think is that we promote as a red flag in the pre-hospital setting may not be a red flag when we get to ED or maternity units. What we know here is that you are suspecting a confirmed suspecting an ectopic pregnancy, then we want to have the diagnostic testing to confirm that in the pre-hospital setting. So something that's a red flag for us isn't always a red flag when we get to hospital. But this tool will support your decision making. As you can see, the action requires time critical assessment in hospital and minimise your time on scene. So maternal collapse and ectopic pregnancy. So maternal collapse has multiple causes, so we must continue to do a systematic approach, even though we are promoting you to think ectopic. Avoid confirmation bias in diagnosis, like Rachel said earlier, even if women are absolutely certain that they couldn't be pregnant. Don't leave that tunnel vision your diagnosis. Ectopic pregnancy must be considered in all women of reproductive age with atypical or unexplained symptoms and an unknown pregnancy status. Ectopic pregnancy can present variably. Less common symptoms may still be clinically significant. Hypovolemia from intra-abdominal bleeding may be overlooked, and we know this from the EMBRIS report that the women that had internal bleeding didn't get the required fluid that they needed. Signs such as abdominal distentation should raise suspicion, and surgical intervention is essential for resuscitation success in ruptured ectopic pregnancy. Always consider the reversible causes of maternal collapse, so looking at your 4Hs and 4Ts. So think ectopic, recognising the warning signs. Typical symptoms of ectopic pregnancy is lower abdominal pain, pelvic pain, missed period or unusual vaginal bleeding, shoulder tip pain, gastroenteral upset or diarrhea, and other reported symptoms are breast tenderness, dizziness, fainting, urinary symptoms, passage of tissue or rectal pressure or pain. Thank you very much.
Thanks so much, Bethan. And now we're going over to Stacey. So she's another lead midwife at London Ambulance Service, and there's a couple of advanced paramedics in urgent care as well that are going to talk about a case. So over to you, Stacey.
Thanks, Cam. Oh, do you want me to share my? Yeah, you got the.
Yeah, do you want me to share them?
Oh yeah, that would be great. Thank
Yeah.
you.
Sorry.
No, that's all right. Thanks, Cam. Sorry.
Bear with me.
Yeah, thanks, Cam. Yeah, good morning, everyone. So I'm Stacey, as Cam said. So I work with her as one of the other lead midwives at the London Ambulance Service. We're really fortunate enough today in that Mark and Hannah are able to join, and will be in the background and will give some reflections, because they were the actual attending paramedics that attended this case review that I'm going to run through. And it follows really nicely from both Rachel and Bethan's presentations, as far as what we can consider a typical presentation for an ectopic case, but with some subtleties that I think that have drawn out some real learning. So I'm going to move through these slides and get started straight away. Thank you. So we'll start with just a timeline, give you an idea on kind of what this family went through at the point of the first 999 call. And I think it really demonstrates that with an ectopic pregnancy, as with a lot of other early pregnancy concerns, families can quite often have several contacts before they have a face-to-face kind of clinician with them in the pre-hospital setting. And so we're going to talk about that. So with our timeline, so this was a couple that were a woman that was woken with acute abdominal pain, and so at 5:15 they made the first 999 call. It was a third party call, which means it was with her husband. So she was present, he was with her, but he was the one who was able to articulate and answer the questions from the call handler, and explain that his wife was about 5 to 6 weeks pregnant, and a previous history of one miscarriage, and now she was experiencing shooting pain into her vagina. There was no bleeding when asked, and therefore the call came out as a category 3. So in London, we use MPDS as our triage within the 999 system, like a lot of other services do. And this therefore came out of category 3. This was peak winter pressures, and as far as the kind of surge of calls, this meant that the category 3 were sent over, as in the call was transferred over to 111. There is also the recommendation that the family make their own way to hospital with this kind of category 3. But they were unable to. This woman was in such significant pain she wasn't able to move. So they then called 111 as advised by the 999 call handler, and it was placed in what's called a validation queue for a clinician within 111 to call back and do an assessment of the woman and her symptoms. And just to note, the 111 triage system is a different system to the 999 as far as the questions. Okay, they run on a different pathway in a triage system. Again, that's quite something to note with our women with early pregnancy complaints. Several hours, unfortunately, went by waiting for this clinician validation. Again, like I said, this was winter pressures. The system is extremely busy, and as far as the categories of call and how to manage how everyone is categorized, this was the waiting time that the family had. But the patient's husband became so concerned that he actually called back on her behalf again, that it was getting worse. At this point, he did say that he was worried that she was starting to go in and out of consciousness, that she would have these waves of extreme pain, and that he was worried that what we now believe to be definitely sort of syncope, transient loss of consciousness, just for short amounts of time, but in and out as she was trying to rest in bed. And this is coming from the family. So I've spoken with the family, and obviously we've got the input from Hannah and Martin as well. So they give a really, really quite detailed history of what they went through that morning. So at this point, when the patient has called back, when the husband has called back and explained that his wife was getting worse, there was an ambulance dispatched. And this included our 2 urgent care advanced paramedic practitioners, and this was because quite often this kind of call would sit. So we're very fortunate in London is our advanced paramedic practitioners in both critical care and urgent care always have a clinician within the control room that will monitor calls to see what jobs will be appropriate for them. And so the urgent care paramedic that day saw this case and said, kind of made the decision that I'm going to send Hannah and Martin for an assessment. And therefore they arrived on scene at 10:13. So you can see the first call from the family was at 5:15 in the morning, and 5 hours later they got a clinician on scene to them. Thanks, Cam. So on-scene findings. So as far as your ABCs are concerned, this patient has a patent airway, but she was tachypneic. She was breathing at a rate of 28 breaths per minute, and she had absent radial pulses. So immediately you're kind of thinking, oh, okay. The husband reported multiple T-lock episodes, and then that became quite evident once the paramedics were on scene and were able to assess her. And of course, she was extremely hypertensive, particularly after these T-lock episodes. Like I've said there, they did quickly recover to a certain amount, but sort of while she had the monitoring on. The patient was able to express her pain, that it did fluctuate. It went between about a 7 to then a 10 out of 10. When the pain was at its worst, it was full on and quite often followed by these syncope episodes. Couple of little things to sort of note. So flatulence, I think it's really, really quite important that we remember this finding that they had, particularly relating to what Bethan and Rachel have said about that bowel irritability and signs of shock. Clearly this woman had her peritoneum was filling with blood at the point of rupture, and there was that irritability, and there was uncontrolled flatulence there that the woman experienced. And then they were able to carry out an assessment. So I think at this point, and also mindful of time, I'm going to bring Mark in, because I think it's really obviously valid to have the clinician who actually attended give a couple of reflections at this point about these on-scene findings. Mark, I don't know if you want to unmute yourself and come in and we'll finish the rest of the slides after you've given a bit of a reflection.
Yeah, no worries. Thank you for having us. I'm just presenting on behalf of myself and Hannah. So Obviously, given the introduction of the NMA, we obviously don't get a lot of information before going to these jobs. And as Stacey has said, we're targeted to jobs like this, such as pregnancy-related pain or bleeding, because we have the pathways to be able to refer these patients to the EPAC units or the EPAU units. Before Hannah and I got there was a somewhat of a presumption that this could have been a miscarriage, because this is really common presentation that we're dispatched to. When we got on scene, we were presented with a sort of horizontal patient with her legs elevated, which kind of made us think that this patient really could have been suffering with hypervolemia or sort of a lot of pain. End bed assessment of this patient, she didn't present critically unwell, but there were some key bits that kind of presented that we felt were out of the ordinary, which was the tachypnea and the tachycardia. But that tachypnea shortly afterward settled a little bit. Whilst at this point I went outside to collect a drugs bag, Hannah continued to examine the patient. She'd done an advanced assessment of the abdomen, which presented absent bowel sounds. It was cold to touch, there was guarding, and there was tenderness in the lower region with severe upper abdominal pain, with no PV bleeding. Following the assessment, whilst I was still outside, the patient had a sudden increase in her pain with the flatulence, and then 2 episodes of loss of consciousness with what looked like some type of posturing while she was there. At this point, the husband revealed to us, because we didn't have this information beforehand, that she had 15 episodes of loss of consciousness prior to her arrival. This was when she had the sudden sort of hypotension, blood pressure dropped to 63 systolic. To us, it was evident at this point we needed to manage this patient in a horizontal position, keeping her very flat and trying not to agitate everything. We gave her some IV paracetamol fluids and some Entonox just to try and help with the pain, and made a quick transfer to hospital. Thank you, Stacey.
Yeah, brilliant. Thanks so much, Mark. Thank you. Can you pop the next slide, Cam? Thank you. Brilliant. So again, as Mark said, it was a case of immediate escalation. So our urgent care advanced paramedics are on a car. So immediately they were calling for a conveying DCA vehicle so that they could get the woman to hospital. The pre-alert was passed at 11:09, and there was a clinical handover in the ED at the nearest emergency department at 11:23. So as far as then what happened to her. Next slide, please, Cam. Sorry. Lost control. There we go. Following handover. So this lady was really sick, as we've alluded to, and as Mark has explained. So she was immediately assessed, and they needed to free up a theatre. Therefore, they started transfusing her in theatre, in the emergency department. She went up and had a salpingectomy, which is a removal of the fallopian tube, which was the ruptured fallopian tube. And obviously she had ruptured ectopic pregnancy, and she required 7 units of blood, and there were several hours in recovery. So where she was in theatre for a relatively normal amount of time that would be considered for this surgery, it took a while for her to be stable enough to come up to the ward after recovery. She was very, very unwell. Thankfully, she was discharged home, and she is well. This was a few months ago, and the family, the couple, are doing well, and they were just, extremely grateful for Mark and Hannah's care. They obviously had some questions, and I think that's part of the discussion that we're having as a wider system, because of as far as the call is concerned. And they were just incredibly sort of helpful and giving as far as their information and their reflections of what happened to them. So I think as far as discussion points, and we can take this as far as the Q&A, and again, it's really good to have everyone on the call, is the contact points. So at what point, does a woman with these early pregnancy symptoms, as Bethan was alluding to, they quite often will have a sort of a lower category call. So this was sitting at a category 3. And so therefore it is sort of sent off to another system to triage and find the most appropriate response. Where do we find that, potentially we can have some more safety netting? I think that's something for concern, so it isn't a 5-hour wait. And this was thankful that the husband advocated for his wife and called back when they weren't maybe getting the answer as quickly as they needed. And then, as we've already said, Rachel explained it brilliantly, and so did Bethan, and then Mark, as far as what their clinical findings were with their abdominal pain presentation, is that this woman was bleeding internally. She had ruptured and was showing clear signs of hypovolemic shock, with the fact that this bleeding was coming from the ruptured ectopic. And I'll stop there, so there's plenty of time for discussion.
Thank you so much, Stacey and Mark, for presenting that case. We're now going to go over to Susie, who's going to facilitate the Q&A. Susie, do you want to just introduce yourself, and then please use the Q&A function, and then we will stop with 1 minute to spare for the evaluation.
Morning,
Thanks,
everybody. I'm Susie Ryan. I'm the Maternity Quality and Governance Lead at North West Ambulance Service. We do have a question in from Sonal from London, and I think this one might be for you, Rachel. It says, due to the area that the ectopic may be, is there any chance of having an ectopic pregnancy with a negative pregnancy test?
Simple answer to that is no. From a clinical point of view. However, we also have to remember that pregnancy tests are tools that can go wrong. And we have known cases where, depending on the quality of the urine sample, depends on the result you get. I know that sounds a bit strange, but if you've got a very dilute urine, it will give off less HCG. And also, if you've got a very heavily blood-stained urine, that would also give off less HCG. So the answer is no, you wouldn't get an ectopic with a negative pregnancy test, but also remember that the pregnancy test has got to be, it's got to have a sample that was a quality sample. If you've got a woman that is bleeding very heavily, blood-stained, then almost you need to discount the results and go straight for a venous blood sample.
Thank you very much. We have a question from, I'm just trying to find out your full name. I can only see a bit of it. I think it might be Mac. In London, it's in regard to the case study. In your assessment, you said that there were absent bowel sounds, but we treated with Entonox. Just wondering what your differentials were. I think this might be for Mark and team. Just wondering what your differentials were for pregnancy related to versus a bowel obstruction.
So initially it was just a case of managing the patient's pain. We hadn't made a full sort of differential diagnosis at that point. It was just a case of trying to manage her pain because she was in severe pain. Then as things progressed, we could take away that Entonox and move over to IV paracetamol to manage the pain a bit better.
Thanks very much, Mark. Claire's asking if you could share the YouTube link first, and then some point, please, Cam. I think, oh, you have done it. So Camilla has answered that and as a response to your question. Do we have any other questions from people? I think there's one more just come in. So we've got Nick is asking, could you clarify why an HCG test abbreviation stands for and what the test shows us? So Rachel, this probably will come to you or any other midwives that we've got on board. Well, Rachel, we'll come to you if that's okay.
Yeah, no problem. So the HCG level, hormone HCG, so it's beta human hormone. It is the pregnancy hormone that is we exclude, and it's in our blood. With a urine pregnancy test, it will pick up that HCG hormone, but because it's also because it's excreted in the urine. But if you can't get it that way, or your sample's not going to be of a good suitable quality, then you can have it done in the blood. So, and we call it beta HCG.
Thank you very much. Simon's asking the question from Simon from Welsh Ambulance Service, and he says, I have access to pregnancy test as an advanced paramedic. Are there any thoughts from the group about the risks and benefits of providing these to paramedics or EMTs in general? So, Cam, I don't know if you've got any thoughts about this.
going to say go to
Sorry,
the
I
others
just put you on
first.
the spot there. Or Stacey or Bethan.
I think that the problem for us is that we go to so many women of those ages, and we have to kind of go on symptomology and signs, signs and symptoms, and be suspicious of ectopic. And also, there's lots of situations where we wouldn't be able to get a urine test. But go to the others as well for their input first.
It'd be interesting to hear from you, Bethan. I see that Simon's in Welsh Ambulance Service as an AP, so obviously they have access to the pregnancy test. So what are your thoughts about having this as a wider diagnostic tool for the rest of your clinicians?
Yeah, I think it's an interesting point that it's great that it's come up for discussion. Like Cam said, there's lots of factors that we need to include in that, and I think for the APPs, especially speaking for WAST, that is promoting us looking at different care pathways. So these women are predominantly well for our APPs, and if we are sending out a conveying resource, what I wouldn't want to do, and this is open for discussion, is to provide that confirmation bias. If, like Rachel said, that test come back negative, but this woman is showing those signs. But it's definitely something that we can think about as a national group, if we think that would aid any decision making. And now we've made these great connections with Rachel, there's something that she can support us with.
I would just add as well that we wouldn't want people to be reassured in either direction. So if it comes back negative, leave them at home, or if it comes back positive, think, oh, okay, well, that's what it is. So that's the other thing, is what is it going to contribute to our diagnosis? Whereas our urgent care specialists, like in London, or your advanced paramedics in Wales, they've got additional kind of skills and are targeted to specific jobs, so have more exposure.
I think also you were alluding to the fact that some of them have direct access, and I think that might be also down to the skill level. You have direct access to EPAU, where that might not always be the case for our on-road in ambulance paramedic and EMTs. Brilliant. Okay, so thanks everyone. Emma Wainwright has got a question. Emma's come from Welsh Ambulance Service. She goes, what is the most effective analgesia regime for these patients, both out of hospital and in hospital? So out of hospital, I think I suppose when you're thinking about any pain management you have, I think Mark has alluded to IV access and gaining IV paracetamol. I think short-term use of Entonox is quite useful. But I would also be considering, and I think you need to think about your blood pressure management. If you are going down a morphine-related route, just think about managing hypertension in that case as well. So does anybody have any other thoughts about how you'd like to manage for patients in the out-of-hospital area? But what about, Rachel, when they come into hospital, what sort of pain management are you looking at there?
So very similar. We would go down the morphine route, but I suppose we're in that position where, with monitoring and accessing surgery, then they're not going to need that for very long, but just that interim gap of, transporting them to theatre. Ultimately, the treatment here with this kind of patient is surgery. So you're going to expedite the surgery, and we'll use whatever pain relief while we're waiting on that, but mainly IV paracetamol and morphine is the route we would go.
Right, that sounds quite similar to us, doesn't it? So we've got Sarah Bear from the Welsh Ambulance Service, and it says on the risk factor slide, it said that the sterilisation can be a risk factor. Does that mean that they can still have an ectopic pregnancy even though they've been sterilised? Yes. Rachel or Bethan? Yes, yeah. Yeah. Big nods. I think we can confirm, Sarah, that is indeed the case. We have Teresa. Oh my lord, your name just popped over there. Do you have any useful websites or resources to help estimate blood loss in different sanitary pads?
No. We've got nothing, and we totally appreciate how hard it is as a midwife. We no longer estimate blood loss because we know that we're not very good at it. We measure our blood loss. all we can say is that make sure that you're taking everything that's got any blood loss that can be moved from the house in with you to the hospital, so that they can weigh blood loss, so that they have got a better estimation of the amount of blood loss the woman has.
I've always valuable.
Oh, sorry, Susie. I was just gonna. I tend to advise, going on what Bethan was saying. You know, companies now market it so that the blood loss isn't visible, and that it's super absorbent pads, and they make it really difficult for us. And that's how they make their money. I tend to advise clinicians turn the pad over, so you know, because you can see the blood sort of where it's pulled within all those different absorbent layers, and sometimes that can give a little bit more of an indication on sort of the blood loss as far as a soaked sanitary pad. When you're looking to sort of estimate, which is what we can do in the pre-hospital setting.
And I think then pulling that back to the remote world, where it's going to be even more difficult, it's just having that curiosity to ask more questions and getting as much information as we can about the pads. And we know the statistics for Black and ethnic minority groups. So if you do need to use language line, can we just promote that is used, so that we are speaking to women in their first language, so that we are really getting a good triage of care.
Thank you very much. I think also it's really important that even if we are trying to estimate blood loss, as Bethan just pointed out, it's a very difficult thing to do. And we're also looking at those clinical signs and symptoms. I think that they're going to be the driving force of us, you know, looking at how critically unwell this woman might be, because different blood losses obviously will affect people of different sizes, etc., etc. So I think even when we're estimating it, it's fine to try and estimate, but actually we're working on those clinical signs and symptoms. Just muted myself as I was talking, so that's excellent, isn't it? All right, so Eric, we have Eric Mobbs from Yorkshire Ambulance Service, and he says, what are your views on how we can improve triage prior to ambulance discharge for patients such as these? The case study and headlines Camilla showed in her slide seem to suggest that these are missed relatively often at great detriment. Cam, I don't know if I want to bring you in on that one. Dispatch. Or do you want me to? Or Stacey, whichever.
Go for it, Stacey.
Yeah. No, it's okay. It was just, I think, with the slides and everything. So I think it's definitely a discussion point. They've done, both Cam and Bethan, sorry, that are on the panel, have worked with the triage unit, and there are some improvements as far as the triaging and screening for women, to try and make sure we're not missing these the women that have become very unwell with an ectopic pregnancy. It's not perfect, and I think it's definitely a concern when we see cases like this case review, when you hear of families that have been waiting for a long time. I think it's a discussion point. I think it's something to take back, particularly with the referral. So if something sits at a category 1, could we have a future discussion in that actually it's assessed by a clinician who just has a little bit more freedom to make that inquiry, as far as, you know, asking, you know, I thought it was of note that when you listen to the call, they explain that please contact 111 or make your own way to hospital. And he said, you know, and he said, you know, I can't move her. I really can't move her. Could we have a safety net or a prompt that there's actually, I'm going to get a clinician to contact you. So either a paramedic in the clinical hub or a doctor in 111, and something a little bit. But, you know, this is, you know, one case in probably what was over 7,000 calls that London received that day. And so it's a very, very difficult with the generic nature that is triage. But obviously you know, this was a long time that they waited for an ambulance.
And I would just add that the international dispatch system have agreed to change the ectopic screening question. So if this case was to happen again after the next version update, then the woman would get a faster response.
And I think what we're doing today, this is how we improve triage systems. We get the word out there by everyone on your telling your colleagues about this today, and getting everyone just to think and have that curiosity around ectopic. And this is what we need to do. We need to make sure that we look into our clinicians and teaching them all about the ectopic pregnancy. So I think even this today will help improve that clinical triage.
Okay, so we reached 10 o'clock now. The Q&A session has complete, but we do have outstanding questions here. And what we can do, Cam, I believe, can we answer these questions as comments? Will they be able to access those, or
Yeah,
is that means to do it so that we are sure? Lovely.
yeah, exactly. So if the panel don't mind just to go into the Q&A and answer the questions, that'll be really helpful. And in the meantime, I'm just putting up, can you see the evaluation slide? The QR code? Yeah.
Yeah, we could see it.
Perfect. So if you don't mind just to fill in the evaluation form, this will just help us to improve on future webinars. And also there is a question at the end there about future topics. And once you've done your evaluation, you'll also get a certificate for attendance today. And I've just put up a reminder there again about the conference and our national email address. So thanks so much for coming, and thank you to our wonderful panel, Rachel, Stacey, Mark, Bethan, Susie. Thank you so much for coming today and giving this opportunity to talk about ectopic pregnancy. And we've had over 200 people from around the country joining, so it's awesome to see so many of you coming today. Thank you.
I've had to join back because I lost the questions.